Hello and welcome, everyone. Thank you for joining us for our webinar entitled Keeping It Renal, Optimizing Urine Sediment Analysis to Improve Patient Outcomes. My name is Danielle Hummel-Johnston. I am a technical product specialist in hematology and urinalysis with Beckman Coulter. I have over 20 years of experience in laboratory medicine. I've held various positions in the laboratory, such as hematology and blood bank technologist, hematology coagulation and urinalysis charge technologist, and phlebotomy supervisor. I obtained my Bachelor's of Science in Medical Technology from Michigan State University. I have the pleasure of introducing you to Dr. Giselle Prada-Wright, who is a urinalysis product manager at Beckman Coulter. Dr. Prada-Wright has more than 8 years of experience in healthcare through her various positions treating patients at different hospitals and outpatient clinics. She has presented her original research at conferences and within academic publications. Dr. Prada-Wright possesses a bachelor's degree in biochemistry from the University of Miami, a doctorate of medicine from Florida International University, and a master's in business administration from the University of Florida. Please welcome Dr. Giselle Prada-Wright.
Hello, everyone. My name is Giselle Prado-Wright. Thank you for that great introduction, Danielle. During this first part of the webinar, I'll start with our why and the reason we're hosting this educational webinar. Then we're going to move to a broad overview of the renal system, highlighting how the urine sediment is a fantastic tool for identifying illness and diagnosing diseases. My colleague Danielle will then discuss particle identification using the DXU iris system, and we will end with some common cases to test your knowledge. As we all know, lab test results are critical for medical decision making. For physicians, diagnostic test results are incredibly important. Many of today's medical decisions depend on laboratory test results being reported in a timely fashion, showing the important role of clinical laboratories in today's healthcare system. In fact, 70% of today's medical decisions depend on laboratory test results. Testing is the foundation for how doctors treat most patients and provides necessary information that can save lives. The most common use of urinalysis is usually to detect substances or particles that help diagnose diseases or screen for health problems. In some cases, kidney disease might be suspected based on what is found in the urinalysis. Experts estimate that 40,000 to 80,000 deaths occur annually from preventable diagnostic errors. One of the leading causes of medical misdiagnosis is the failure to accurately communicate test results. When abnormal test results are not properly reported, the consequences to patients can be serious or even fatal. If the test results are not communicated in a timely and appropriate manner to the patient, and that patient subsequently suffers harm, this could be the basis of a medical malpractice lawsuit. Let's investigate how urinalysis can facilitate renal disease diagnosis and treatment. Urine sediment examination is a biomarker in the sense that it is a biological measure that is objectively measured as an indicator of a normal or pathologic process in the kidney. It's used for clinical assessment in individuals to predict or diagnose kidney disease, monitor the course of a disease, or the response to therapy in those with known kidney disease. Doctors are often like detectives, in that the information gleaned from urine sediment examination frequently leads to diagnosis and formulation of an appropriate therapeutic plan. Urinalysis in particular is an inexpensive, easy to perform, and easily interpretable test. Particles can be stable for several hours, further facilitating analysis. Here we can see a close-up of the nephron and its place in the kidney. The labels on the kidney cross-section show where unfiltered blood enters, filtered blood leaves, and where urine is collected at the end. There are many different types of renal injury. These can be classified as pre-renal, intrinsic renal, or post-renal. Pre-renal is caused by decreased renal perfusion, often because of volume depletion. In fact, 70% of cases of acute kidney injury are due to a prerenal injury. Intrinsic renal is caused by a process within the kidneys. The most common type of injury here is acute tubular necrosis. This is associated with high morbidity and mortality. Postrenal is caused by inadequate drainage of urine out of the kidney. The most common cause here is prostatic hypertrophy in older men. Urine sediment examination, especially when combined with dipstick urinalysis, can provide important information about the kidney compartment involved, whether that's the glomerulus, the tubule, the interstitium, or vasculature. In the glomerulus, RBCs can often be seen when there is damage or inflammation in the glomeruli. White blood cells can also indicate inflammation. You can also see increased protein levels. One common glomerular condition is glomerulonephritis. For tubular injury, this is the most common site of acute kidney injury. Acute tubular necrosis is one type of AKI that's commonly seen in hospitalized patients. It's associated, like I mentioned earlier, with high morbidity and mortality. Acute tubular necrosis is precipitated by an acute ischemic or toxic event, or even sepsis. In the interstitium, this broadly refers to kidney diseases that involve any structure in the kidney outside of that glomerulus, tubule, and vasculature. For the vasculature, this is very commonly observed. It's usually due to the effects of hypertension on the vascular wall. Renal vascular disease affects the blood flow in and out of the kidneys. This can cause kidney damage, kidney failure, and high blood pressure. So let's take a closer look into the particles typically associated with each compartment. With glomerular injury, you'll see the following in the urine sediment: red blood cells, RBC casts, white blood cells, cholesterol crystals, especially common in nephrotic syndrome, and healthy glomeruli stop serum protein from being lost in the urine, so you'll also see increased urine protein levels in patients that have suffered glomerular injury. White blood cell clumps are typically found in urine samples that contain large quantities of white blood cells. Their presence generally represents acute infection or inflammation of the renal and urinary tract. UTIs can present with white blood cells and white blood cell clumps. Clumping is usually due to increased mucus present in the urine. Diving deeper into cellular casts, these also indicate renal disease. Cellular casts are a solidification of material, usually protein, in the lumen of the kidney tubules. This can be composed of any of the cells found in the urine sediment, such as RBCs, WBCs, or renal tubular epithelial cells. If you see cellular casts in the urine, it's known that the cells are present in the kidney nephron. Fatty casts are another type of casts that are also a protein matrix containing fat inclusions. It's related to nephrotic syndrome, diabetes, and mercury intoxication. Fatty casts contain globules of fat, either present as triglycerides or neutral fat. These can be visualized with fat stains, or they'll actually polarize under microscopy as a Maltese cross. Acute tubular injury is an injury to the filtering tubules of the kidney. Tubular injury is characterized by the following particles: renal epithelial cells, muddy brown casts, albumin in the urine, especially common in hospitalized patients. Tubular interstitial injury is located in structures in the kidney outside of that glomerulus, tubule, and vasculature. The common particles seen here are WBCs, renal epithelial cells, white blood cells and granular casts, and a negative urine culture. If you see a negative urine culture and white blood cells, this is a high suspicion for acute interstitial nephritis. Some of the common causes for tubular interstitial injury include drugs, infectious diseases, or immune mediated. Some of those common drugs are antimicrobials, NSAIDs. For the infectious causes, you can see cytomegalovirus, HIV, salmonella, streptococcus, leishmania, and toxoplasma. For immune mediated, these tend to be lupus, sarcoidosis, Sjogren's syndrome, and inflammatory bowel disease. Renal epithelial cells are found in nephrotic syndrome and in conditions leading to tubular degeneration. The number sloughed off will increase in these conditions. They can also indicate kidney involvement. Renal epithelial cells will be present in cases of acute tubular necrosis, renal transplant rejection, viral infections like cytomegalovirus, and certain drug or heavy metal intoxications. Renal epithelial cells can also help differentiate from an upper and lower urinary tract infection. Increased renal epithelial cells are typically found in upper urinary tract infections, while increased transitional epithelial cells are typically found in lower urinary tract infections. Now, granular casts. They're typically associated with acute tubular injury. These can help guide the differentiation between pre-renal and overt tubular insult. If a high concentration of granular casts is present or they're seen in sheets, this is considered a symptom of acute tubular injury. It can also be associated with a greater likelihood of dialysis requiring acute kidney injury, so it's very serious. Last, vasculature. It's very commonly observed. Renal vascular disease affects the blood flow in and out of that kidney. Any blockage or narrowing of the arteries can affect the amount of renin secreted by the kidneys. Renin helps to regulate your blood pressure. So any vascular injury can cause kidney damage, kidney failure, and high blood pressure. Automated urine analyzers that capture images of all sediment particles can help labs provide accurate and clinically relevant results. I'll hand it off now to my colleague Danielle, who will tell you more about the DXU Iris solution.
Dr. Prada Wright has reminded us of some of the common injuries faced by our patients and the importance of accurately reporting these particles to our physicians. Beckman-Coulter's DXU Iris is a great solution for detecting these particles discussed by Dr. Prada Wright. I will discuss the technology behind the DXU Iris and some features of the DXU Iris that will help streamline your workflow. The Iris comes from a legacy of 30 years of excellence in urinalysis automation. The DXU microscopy series consists of the DXU 850M Iris and the DXU 840M Iris. Both systems offer the optional body fluid module, which will help standardize cell counts and workflow. The DXU offers extensive classification capabilities. The Iris system can report your patient's results qualitatively or quantitatively, depending on your facility's preference. It can also store up to 10,000 patient records on board, which can provide additional teaching and training for your staff or be used for further investigations. Timely identification and comprehensive digital images for all patient samples can improve patient outcomes. The DXU Iris delivers accurate results by using digital flow morphology to automatically isolate particles. These particles are then further analyzed based on the size, shape, contrast, and texture to auto-classify into 12 categories and 27 subcategories. Each particle is categorized with a 90% or greater confidence interval, so you can be sure you are auto-releasing samples with confidence. This proprietary software allows for a quicker turnaround time and reduced manual review rates. APR is like facial recognition software in that it identifies specific characteristics of a particle to classify it into the appropriate category. The Iris analyzes the size, shape, contrast, and texture of a particle before it classifies the particle. Classifying based on 4 different specific features allows the iris to classify your urine particles accurately. Life's too short to be manually reviewing all of your urines. Edit-free release software allows you to auto-release results without tech intervention to meet your turnaround time needs. Your laboratory has the flexibility to establish parameters for auto-releasing results based on user-defined particle verification range. This allows for only samples needing to be reviewed to appear on your work list. Edit-free release will increase your workflow efficiency by allowing the technologist to focus on the more critical patients. Implementing edit-free release allows for a reduction of sample processing time by optimizing your auto-release rates. The DXU also features eyewear, which is an integrated urinalysis software that provides onboard validation and result verification into a single step without the need of middleware. The software helps laboratories become more efficient as it reduces manual steps to increase standardization in the validation process. In a recent study, the iris showed a 3% false negative rate when eyewear was implemented in the laboratory, providing the lab with accurate, rapid results. The DXU will provide you with the highest auto-release rate possible, but when you do have an abnormal particle to review, we want to make sure you have the digital image to look back on. What makes the iris so different when compared to other microscopy analyzers is that the DXU provides digital images for all your patient samples that require a microscopic analysis. This allows for personalized patient care and no additional analyzer reflexing is necessary. Having the images is great for training and competencies. If your physicians want a printout of the image on the report, the DXU iris can provide that. Beckman Coulter is committed to providing the best tools to streamline your workflow. A great example of this is through our optional Command Central software. Command Central helps workflow efficiency by giving the ability to remotely interface with your DXU. This allows for remote review, editing additional classifications if necessary, and releasing results without having to physically return to your analyzer. You can accomplish this from up to 5 review stations. You have access to your analyzer if you are in the laboratory or sitting at your office. The DXU streamlines results and provides personalized patient care by providing digital images for all samples, so you know your lab is not missing those clinically relevant particles. It also provides rapid identification and automatic classification through our proprietary auto particle recognition software for shortened turnaround time and a low manual review rate. Now I will turn it back over to Dr. Prado Wright for Test Your Knowledge.
Thank you, Danielle. Now we're going to use patient presentations and clues from the sediment analysis to test your knowledge on how a doctor would diagnose and typically treat these patients. Let's see if you can get these 5 renal diagnoses correct. Our first patient is an elderly patient. She's got no significant past medical history. She's presenting with poor skin turgor and dry mucous membranes. The sediment analysis shows hyaline casts. So what do you think the physician's diagnosis would be, and how would we treat this patient? If you thought pre-renal AKI, then you would be correct. The treatment here is IV fluids in order to get that volume back up in the patient. Now we have a female patient with a history of lupus. She's presenting with bloody urine and she's got highly elevated blood pressure. Her sediment analysis is showing RBCs and RBC casts. How should the doctor treat this patient and what's the likely diagnosis? Our diagnosis would be glomerulonephritis. For the treatment here, we're thinking of a kidney biopsy and steroids. Now a patient that's been treated previously for pyelonephritis with antibiotics. The patient has oliguria and a new rash. Our sediment shows white blood cells, but the urine culture comes back negative. How do you think we should diagnose this patient if you were the doctor, and how would you go about treating it? This is a classic case of acute interstitial nephritis. The treatment here is to discontinue those antibiotics, start some steroids, and possibly order a renal biopsy. This is a male patient with a history of uncontrolled diabetes. He's got foamy urine and a lot of edema. Our sediment analysis shows cholesterol crystals. What should the diagnosis be and how should the physician treat this patient? If you guessed nephrotic syndrome, that would be correct. The treatment here is IV diuretics, a low salt diet, and a renal biopsy. Now we have a female patient. She's got no past medical history. She's having some dysuria and cloudy urine. Our sediment analysis shows white blood cells and bacteria. How should we treat this patient and what's our diagnosis? The diagnosis here is a urinary tract infection. This can be treated with oral antibiotics and possibly a urine culture to specify what type of bacteria we're looking at. Thank you for participating in our Test Your Knowledge. You can see the importance of how the urine sediment provides clues that assist physicians with accurately diagnosing patients. The urine sediment is an ideal biomarker. Sediment analysis can even locate the location of kidney injury, and rapid identification and digital imaging of the sediment for all patients can improve outcomes. Thank you for joining us today, and please check out our related resources at beckmancoulter.com.